So in general information, clavicle fractures are common, accounts for 5 to 10% of all clavicle fractures, up to 44% injuries to the shoulder girdle, easy to recognize and majority unite uneventful. The clavicle is an S-shaped bone. Lateral third is a flat and is the insertion site for the trapezius. The middle third is tubular and provides protection. The medial third is quadrangular and it is the insertion of the sternocleidomastoid muscle, because you must know the anatomy before you do the surgery. The function of the clavicle everybody knows. It holds the arm, protects the underlying neurovascular structures and transmits the forces from upper limb to the axial skeleton. What are the deforming forces that are causing the fracture displacement? A sternocleidomastoid muscle pulls the medial fragment upward, weight of the limb pulls the distal fragment downward, and trapezius and pectoralis muscle helps for overriding of the fragments. And before you do the surgery, you must plan according to the muscle forces. Now there is a classification according to the site of fracture, that is Ullmann classification. Group 1 middle third, most common. Group 2 distal third and group 3 is the medial third. What we are talking mostly on the middle third clavicular nailing. Now Robinson classified into type 2 fractures, that is a simple fracture and comminuted fracture, whether 2-part, 3-part or a 4-part fracture, and depending on the treatment plan changes. Now how to do a radiological evaluation? Antero-posterior view, and there are another two views used to be taken, 30-degree cephalic tilt view and 45-degree orthogonal view. Though in the AP view it looks undisplaced fracture, probably it is widely displaced in a cephalic or orthogonal view. Therefore, before you start treatment, that is also very important. The goal of treatment is achieve bony union with minimal morbidity, minimal loss of function and minimal residual disability. There are triplet options are open: non-operative treatment and surgical treatment. In surgical treatment, we have a two option, that is a plate fixation and intramedullary nail fixation. The non-operative treatment, it is given by sling or figure of 8 bandage. Unclear about the need to wear a specialized brace because it does not do good. Most of the shaft clavicle fracture is healed by conservative treatment. Fallacies of non-unit treatment: it is difficult to reduce clavicle fracture by close means and to retain it also. Significant displacement of a mid shaft and distal third injuries have a higher incidence of malunion, non-union, and now in recent report it is 15 to 20% of the non-union is reported in displaced mid-clavicular fracture. So conclusion of MIC study: displaced mid-shaft clavicular fracture can cause significant persistent disability even if they heal uneventful, and therefore now there is a resurgence of the surgical treatment, and there are various many surgical treatment clavicular which is advised. There are some absolute contraindication indication, and some of them there are relative indication. But widely displaced fracture in a multi-traumatized patient, open fracture and associated neurovascular injuries, they are the main indication for the internal fixation of the clavicular fracture. Relative indications like floating shoulder, seizure disorder, cosmetic deformity and earlier return to work, but mostly it is because of the widely displaced fracture. Plate fixation, traditional means of ORIP, plate applied superiorly or inferiorly. Inferior plating associated with the lower risk of hardware prominence, used for acute displaced fractures and non-union. Anatomical reduction and fixation by plate is always excellent. Constant and DASH score significantly improved in ORIP group as compared to the conservative group. Hardware complication and non-union and refracture we have to look for. There are very many wound complications are described in the fracture of the clavicle by open method. So complications of non-operative treatment, non-union is 1 to 5%, whereas this decreased shoulder strength and endurance, whereas complications of operative treatment is supposed to be 10 to 30%. And there are various complications, hardware complication, there is a plate removal, adhesive capsulitis infection, and there are so many other things. Because X-ray looks good, but functionally the patient, if it is not done properly surgery, then there are so many complications. So, it's a medullary fixation, again it coming up, large threaded cannulated screws, flexible elastic screw, nails, K-wires, where they are associated with risk and useful when plate fixation is contraindicated, that nailing is a resurgence. So, one of the best method now it is open reduction and internal fixation by nail, and it has been well described method by Rockwood and Green as well as McKeever, that they give a retrograde nailing by opening and retrograde putting, and there is a cap at the end so that there should not be a migration of the nail. Now, there are the tightening elastic nails, they have come up, accommodate three-dimensional anatomy of the clavicle, typically inserted retrograde from the medial to lateral or from lateral to medial, best is fracture without comminution, and small incision at fracture site may is expected. So, it is a very good method, but minimally invasive nailing of a mid-shaft clavicular fracture, and the literature report said it is a recent 31 cases studied in a 7 cases medial migration and 1 case of lateral migration, which necessitated there is a early removal of the nail. And therefore, another study again, the major complication not a union and deformity correction, but here also in the 7 cases of medial nail migration, and there is a after removal there is a 1 refracture. So, as compared to the plating as well as the this conservative treatment, nailing scores, but there is a constant problem of a migration. And how? So, therefore, to nullify this migration problem, interlocking nailing for fracture clavicle has been devised, and they have also given a very good result, but technically it is a demanding, and if through a very small hole it is very difficult to do a interlocking nailing. Therefore, I have devised a new concept in the treatment of clavicle fracture with a screw intramural level, which will prevent migration of the nail. And moreover, in a comminuted fracture, because of migration problem and because of the shortening and shrinking of the comminuted fracture, nailing, elastic nailing as well as the other nails, they don't work unless they have been locked. Therefore, a screw intramural nail 5 to 6 centimeter in length, 2.3 mm in diameter, screw portion 10 mm in length and 4.5 mm in diameter, and screw hole of 3.5 mm at the end. I have a nail, Dr. Sahab dikhaiye. This is I used for a forearm mostly, and so why not, actually I have done more than now 200 cases for forearm fracture, so why not to apply this same. So this is how it is, the nail, this is made up of both steel as well as elastic, and you can have this is the screw end and you can screw it like this. So I will show you the video also, and this is a malleable, it can go here and there, but it should not be more than less than 2.5, otherwise it doesn't work, and should not be more than 3 mm, otherwise it is too stiff. So it between the 2.5 and it should be upon the 3. So screw nail is an elastic nail. Nail is made up of metal sufficiently elastic to bend. It is traverse the canal from the point of insertion and resilient enough to spring back in the curvature when finally seated. Rigid enough to withstand the torsional, rotational and angulatory forces. Suppose if you use a very thin nail, probably it will not work, and very rigid nail are more than 3, the problem of stiffness. The procedure, the screw nail is mounted on a chuck. The inserter should firmly grasp the nail in the order to control rotation, insertion and nail withdrawal. Now know the anatomy before you do the nailing, because the medial end is a soft bone. So the nail should be inserted from the soft bone. Moreover, we have to look for the subclavian vein as well as the brachial plexus. it is going, so that the entry point should be exactly, otherwise if you go here and there, probably you may damage the vein and the nerve. Therefore, medial entry point, close nailing is a more difficult, and we must know the anatomy of the medial end of the clavicle. So, patient position on the place the patient supine with a large bump placed between the scapula, allowing injured shoulder girdle to fall posteriorly, so that the medial end as well as the clavicle become more prominent. This position helps to restore length and increases the exposure of the clavicle. Image intensifier is must. Medial entry portal near the sternoclavicular joint. Window near the sternoclavicular joint, bone hole is fast and entry point is enlarged. Reaming of the canal from the medial end till the fracture site. And there are very 2 mm, 2.5 mm flexible reamers are available, even forearm reamers also you can use. Unless you ream and assess the canal, don't put the nail, otherwise it will hit and probably it will not go. Because if you are not able to negotiate more than 2 mm, it is better to open and do a plating, don't do a nailing. So it must accommodate more than 2.5 to 3 mm. Introduction of the nail and negotiation till the fracture site. You don't attempt at reduction till that end. Our nail should go to the fracture site, and then reduction of the fracture with the help of the towel clip. You have to reduce both the end, you put the towel clip at the end, and then with the rotatory movements and transition here and there, anterior, posterior, lock the fracture site, and then you pass the nail. So negotiation of the nail through the fracture site, this is very crucial stage. Monitor every step in the C-arm. Otherwise, if you put the nail below down, so there is a brachial plexus. So don't damage it. Therefore, it is a very crucial. You reduce the and then you pass the, otherwise don't do by the nail the reduction part. After 2-3 times, if you are not able to negotiate the nail, give a very small incision and deliver the fracture site, open the fracture site and then pass a nail. Very small incision, just you look for the. So, minimally invasive, this is the method. Minimally invasive, probably a stitchless surgery sometime, but if you at all, if you want to give an incision, you can give a small incision. For the beginner, I say, the small incision should be given for some time to locate the fracture site, and then you negotiate the nail. So these are the examples, a displaced midclavicular fracture. This is the after follow-up after 2 months, another displaced midclavicular fracture, and you can see 10th month follow-up. There is a perfect union in a comminuted even fractures of the clavicle. There I have innumerable examples of the displaced clavicle fracture with a butterfly fragment. Don't do anything, it unites and heals up. This is a 4-month follow-up. This is another X-ray displaced 4-month-old mid-clavicular fracture, 6 months. Now patient was symptomatic. I did a open reduction, correction of the symptomatic non-union with the intramuscular nail plate. So, comparison of the plate and nail. Now this is how it is. This is that there is a very large incision you have to give for the plate, because newer plates are coming up, and I believe today also I love to do a plating, anatomical plating. There are anatomical plates of them, locking plates with hybrid plate also. And if you ask me what is the best and simple method, is the plating method. Number of times I do it, but nailing is a difficult procedure. If you are able to succeed, you will probably give a scarless surgery. So, intramedullary nerve, open or close method, medial entry, easy procedure, limited exposure, disadvantage narrow canal, difficult rotational control, and sometimes you may have a pin migration. So, plate fixation versus intramedullary fixation of displaced midclavicular fracture. High quality evidence from 1 study and low evidence from 3 studies showed no difference in functional outcome or complication after plate fixation or intramedullary fixation for a displaced mid-shaft clavicular fracture. So, if there is no difference after a treatment, if you can give a scarless surgery or you can give a very small stitchless 1 or 2 surgery, it is always better. That is the contention. Identify the indicated cases for surgery and select appropriate implant. Nail migration is prevented by screw intramedullary nail. I will provide a video also so that we can have then discussion. These are the instruments. These are the instruments, the screw intramedullary nail, then there is a screwdriver, bone awl, and towel clips. You can have a reamers also. Reamer is must. Then this is the site of incision at this sternocleidomastoid junction, sternoclavicular junction. Dilate the wound with the, this is artery forceps. Then this is the bone awl. We have to see constantly because it should not go here and there. Then this is the curved hole. First you use a straight hole and then curved hole. And then you can feel if it is inside the canal, you can manipulate the fracture fragment, and this is the reamer. We have to ream till the proximal fracture side. When there is a curvature, there is a difficulty in reaming also. You may get a resistance, so that you require a flexible reamer. Now you can see this is the place where there is a difficulty in reaming because of the curvature. So it takes time for negotiation of the reamer also at that fracture site junction. Now this is how it is. Now you can manipulate also the proximal medial fragment. Then you can have a trial reduction also. This is with the towel clip. You align with the medial fragment, and this is, it is aligned, and you can feel if there is a rimmed one, you can feel that the nail is hitting to the other side of the fracture. Then
how many minutes of CR do you use? Do you keep track of how much CR you're using?
At the time of this negotiation, then it has to be the constant. So now you can see that the fracture side has become stable, and then we have to negotiate the nail. Now it is going inside. And this is with the screw intramedullary, we can last. It is going inside. And this is out. It should be it should cross the sternoclavicular joint. And you can see this is the small incision. This is a very small. Suppose you are not able to negotiate, give a very small incision, reduce the fracture, and then you can also negotiate. Usually nail grows near about 1 centimeter short of the this is the acromoclavicular joint. So you can see, you can compress the fracture site. So nail also takes shape of the clavicle, but there is some loss of curvature is there. This is small incision if you want to open it, and this is how it is post-operatively. You can do all types of exercises, but we prohibited exercises for 3 weeks, overhead exercises. This is small incision. Okay, thank you very much.